Welcome back to your Pediatric Dentist channel Tiny Teeth Talks. If you are new to this channel, subscribe the channel, and for details of this channel visit the bio section, or you can also check out my first video. Today we will discuss natal and neonatal teeth, one of the most important topic in pediatric dentistry. So let's start. First, understand three terminology. Prenatal teeth. Teeth that are developed and present in the oral cavity before birth is known as prenatal teeth. Natal teeth, teeth that are present at birth. And neonatal teeth, teeth that erupt within the first 30 days of life. These teeth are typically part of the primary dentition but may occasionally be supernumerary. Coming to the classification, so the classification of natal and neonatal teeth is based on their degree of development and attachment, which was proposed by Messler and Savara in 1950. Based on their degree of development and attachment. So degree of development, mature teeth and immature teeth. So mature teeth, fully developed crowns and roots and resembling normal primary teeth. In immature teeth, incomplete development, often with the hypoplastic enamel and dentine. In attachment, firmly attached and loosely attached. Firmly attached teeth stable and well anchored in the alveolus, and loosely attached teeth mobile and at risk of aspiration or early exfoliation. Then Spouge and Fisby in 1966 give the classification based on the morphological appearance. Same classification is modified by Hebling in 1997. So these are the Spouge and Fisby classification in 1966, and these are Hebling in 1997. Let's see both together. So in type 1, shell shaped crown with no root loosely attached. Same shell shaped crown poorly fixed to the alveolus by gingival tissue and absence of root. In type 2, solid crown with no root loosely attached. Solid crown poorly fixed to the alveolus by gingival tissue and little or no root. Type 3, eruption of the incisal edge through the gingiva. Same eruption of the incisal margin of the crown through the gingival tissue. In type 4, edematous gingiva with the tooth unerupted, edema of the gingival tissue with an unerupted but palpable tooth. So gingiva becomes swollen in this category and inflamed, which is edematous over a tooth that has not yet emerged into the oral cavity. Let me tell you a small story of history of natal teeth. So before the normal time, there are several terms used for natal and neonatal teeth like congenital teeth, fetal teeth, predecidual teeth, and dentitia precox. Then Messler and Savara in 1950 gave the name natal and neonatal teeth. So the long before modern dentistry existed, babies born with tiny teeth already in their mouth sparked wonder, fear, and plenty of wild beliefs across the globe. The story begins in ancient Rome, where a historian named Titus Livius, back in 59 BC, saw natal teeth as a sign of doom, which is something bad happened. On the other hand, another Roman thinker, Quintus Livius Secundus the Elder, had a different take in 23 BC. He believed that boys born with the teeth were destined for greatness, perhaps future leader or heroes. But girls, oh no, for them the same teeth were thought to bring bad luck. The mystery of natal teeth continued to capture imaginations across the ages. In some African tribes, people feared these unusual babies so much that tragically they believed that the children would bring misfortune to everyone they touched. In Chinese children, they believed that when these natal teeth would start to bite, one of the parents would die. Meanwhile, over in Europe, the views couldn't have been more different. In England, people thought babies with the natal teeth were destined to grow up as a brave, famous soldiers. In France and Italy, they were even further, imagining that these children would one day conquer the world itself. Can you imagine the expectation placed on such a tiny teeth? So coming to the prevalence, natal and neonatal teeth are rare, with an estimated prevalence of 1 in 2000 or 3000 live births. The approximate ratio between the natal and neonatal teeth is 3 is to 1. Katz et al. In 1984 said more predilections in female with the 66% and male 31%, so more common in female. According to Almeida and Gomide, 1996, high prevalence is seen in children with the cleft lip and palate. Affected teeth, mandibular central incisors are most commonly affected. According to the Bodenhoff's study of natal and neonatal teeth, 85% are mandibular incisors, 11% are maxillary incisors, 3% are mandibular canines and molars, only 1% are maxillary canine or molars. Coming to the etiology, over the years, the cause of premature eruption, including hypovitaminosis, hormonal stimulation, trauma, febrile status, and syphilis, but a cause and effect relationship has not yet been established. Then the current concept suggests that the natal and neonatal teeth are attributed to a superficial position of the developing tooth gum, which predisposes the tooth to erupt early. The tooth was not located in an alveolus but slightly below the surface of the alveolar bone, very much above the gum of a permanent successor. And Boyd and Miles proved with the study. Genetic and hereditary factors, family history. Holt and McIntosh described natal teeth appearing across the three successive generations, with the family emphasizing the hereditary nature. Hyatt noted the presence of natal teeth in 5 siblings from the same family, associated with multi-system syndromes and developmental abnormalities. So Alice van Creveld syndrome, Hellermann-Streiff syndrome, Pierre-Robin sequence, providing the evidence of genetic contribution. Coming to the histology. So enamel, most crowns are covered with the hypoplastic enamel, and the enamel layers are thin and underdeveloped, showing varying degree of severity. This hypoplasia can make the teeth more prone to wear and damage. Dentine. Hawkins in 1932 shows irregular dentine close to dentino-enamel junction as well as large pulp chamber. Microscopically irregular interglobular areas with the structures resembling osteodentin have been observed, as well as an atypical arrangement of dentinal tubules, gradual decrease in the number of dentinal tubules from the crown to the cervical region. Cementum. There is a lack of cementum formation, which is critical for anchoring teeth to the alveolar bone. This absence often explains the mobility of natal and neonatal teeth. Pulp. The pulp tissue is ample and vascularized, meaning it has a large volume and is rich in blood supply. This vascularity may contribute to the reddish hue observed in some cases. Friend et al. At 1991, in a clinical and histological report on an upper natal molar, proposed that the alteration in amelogenesis detected was due to premature exposure of the tooth to the oral cavity, which resulted in the metaplastic alteration of the epithelium of the normally columnar enamel to a stratified squamous configuration. Coming to the management, a radiograph should be made to determine the amount of root development and the relationship of prematurely erupted tooth to its adjacent teeth. King and Lee recommended that inflamed gingival tissue around the teeth should be controlled by applying chlorhexidine gluconate gel 3 times a day. In some cases, the sharp incisal edge of the tooth may cause laceration of the lingual surface of the tongue, and selective grinding of the tooth is advisable in such conditions. Most prematurely erupted teeth are hypermobile because of the limited root development. Some teeth may be mobile to the extent that there is a danger of aspiration, in which case the removal of the tooth is indicated. If extraction of the tooth is indicated after the tooth is removed, careful curettage of the socket is indicated in an attempt to remove any odontogenic cellular remnants that may otherwise be left in the extraction site. Such retained remnant may subsequently develop a typical tooth-like structure that requires additional treatment. Earlier, it was recommended to delay surgical procedure on newborns until after the 10th postpartum day due to the inability of clotting, but nowadays it is no longer considered because of the prophylactic administration of vitamin K as a standard procedure in most hospitals. Eruption of neonatal teeth may cause difficulty for a mother who wishes to breastfeed her infant. If breastfeeding is too painful for the mother initially, use the breast pump and bottling the milk are recommended. However, the infant may be conditioned not to bite during suckling in a relative short time if the mother persists with breastfeeding. It seems that the infant senses the mother's discomfort and learns to avoid causing it. The preferable approach is, however, to leave the tooth in a place and to explain the parents the desirability of maintaining this tooth in the mouth because of its importance in the growth. Adjacent teeth would erupt within a short time and the prematurely erupted tooth will become stabilized as the other teeth in the arch will erupt. Complications: traumatic ulceration on the ventral surface of the tongue, frenulum, or the lips is the most commonly associated complication of natal teeth. Ulceration of the sublingual area in the infant was first described in 1857 by Cardarelli. In 1881 and 1890, Riga and Fate described this lesion histologically and it has subsequently been known as a Riga-Fate disease, although a more appropriate descriptive term is neonatal sublingual traumatic ulceration. These are the references. If you want these as a PDF or any other PDF, just like, subscribe and comment your mail ID with the topic and I'll send you the PDF. New videos on Sundays for now. Also, we will put lots of important things on shorts. So subscribe and press the bell icon for that. Like, share and subscribe. Thank you.